Presentations from Erin and Molly and from Rebecca and Emily, and that's really content matter stuff. Today, I sort of want to take a step back and say how we're integrating some of this, some of the subject matter expertise into health system science. I know I gave you an overview back in December, and we'll go a little bit more in detail today, but also during this, give you an explanation of population health from my perspective. And some of this is going to be to make sure that we're consistent across the years. Kelly, I hope you don't mind. I'm going to just share our discussion. Kelly reached out to me over one of the breaks to talk about what he has been doing with respect to how physicians get paid. And one of the sessions that we have in year 2 that Dr. Jonathan Stewart is doing. And what I really hope, this year during faculty development, this is still a work in progress, but moving forward, I hope that we can really make sure that the content that's presented in first and second year is consistent and added value to the content that's delivered in third year. And so we were just having this conversation that we want to make sure that the sessions on how physicians get paid, and that's sort of simplifying a little bit, it is again added value, and that I think really importantly we're consistent. So today we're going to go over definitions of health, population health, public health, things like that. But in the meantime, the key, let's see why it doesn't want to go. Okay. My goal, well, yes, we're going to talk about population health and public health. One of the goals that I have is to make sure that you all understand what we're teaching in the first and second years. And so where you see opportunities for growth, improvement, I would love for you to get involved. I've already sort of gently tried to pull Kelly in and say, well, maybe moving after faculty development, you can teach this session so that we're really ensuring that there's consistency. So really the overarching session objective is to make sure that you know what we're doing in years 1 and 2, and give you an exposure to population health, public health that you may not have otherwise had. So the reality, and we just saw this, the reality is that population health is integrated throughout all of health system science. I don't know how it wouldn't be, but where we emphasize it are in those 2 quadrants, or those 2 sixths. So there's a lot in population, public, and social determinants of health, of course, some of the stuff that we talked about this morning, but it's also interwoven in healthcare structure and processes, in value in health. I mean, it's really integrated into all of it. It's a bit what we talked about last time, that structural, cultural and structural competency are really in everything that we do. It touches everywhere, but this is where we emphasize it. So the next few slides are really just boring slides, and they're really here for your reference. So I think it's 5 slides actually. This is a review of what we talked about in December, just to contextualize it. Speaking of context, contextual recognition. We do an overview. That's where many of you will be teaching. We then go focus on teaming and interprofessionalism, focus on public health and healthcare delivery. So that's what we're teaching right now. And I'll tell you what we're doing in just a few minutes. Block 4, focus on law and ethics. Again, this is review for you. Boots on the ground. I'm going to get into a little bit more detail about that today. We talked about it very briefly in December. Then really focus on health systems and health policy and practice. So this is where billing and coding and how physicians get paid and clinical guidelines, all of that is in policy and practice, and then really transitioning them into interprofessional practice in the clinical setting. So specific learning objectives and these were integrated kind of into that PowerPoint last in December, but here are some specific learning objectives, and you can look at them at your leisure. I'm not going to go through them all, but you can see where we just integrate public health into public health and population health. We'll talk about that difference in just a minute, into all of them. So right now, last week I gave the students didactic and some interactive session on sources of data. Where do data come from? Today, just in an hour or so, we'll be talking to students about leading causes of death. We're going to break it down into actual causes of death. And how many of you, I'm going to see if I can increase how many I can see of you. How many of you have heard that medical errors are the third leading cause of death? So I saw a couple hands out there. How many of you believe, and maybe I should have done a poll here, believe that medical errors are the third leading cause of death? Andrew. All right, so today's session, what we're going to go through is they heard about the leading causes of death, and that's by ICD-10. Those are the definitions. So for 2020 and 2021, it's going to be heart disease, cancer, COVID, right? Straightforward. And then accidents, which includes overdoses as poisonings, and COPD, stroke took over COPD in 2020. So they're going to talk about that. And then we're going to talk about actual causes of death. And this is where we have that in-depth discussion of social determinants of health. So we're going to look at tobacco as a leading actual cause of death. We're going to talk about diet and physical activity. And I'm not sure if you guys know, but diet has overtaken tobacco as a leading preventable cause of death. So we're going to be talking about that today. And then I'm going to introduce the concept of medical errors as a leading cause of death. And what I'm going to have them do, having had them do a sources of data session last week, I'm going to see if they can find data, secondary data. They've talked about primary data and secondary data. I'm going to see if they can do a scavenger hunt and find out where we get good information on medical errors. And what do you think? And I'm just going to look at the chat. What do you think they're going to find about sources of data for medical errors? Feel free to speak up or throw something in the chat. So there's the Institute of Medicine to Err is Human. We are definitely going to talk about that. Triangle Lawyers Association, CDC. So the reality is they're not going to be able to find good data on medical errors. So my point with this is that I want them to learn themselves that we don't have good data sets on medical errors. There are some ICD-10 codes. I'm going to provide them with those ICD-10 codes. But what that's going to do is help them understand some of the limitations of our data, which feeds into clinical informatics, right? We're then going to transition into, regardless of whether it's the third leading cause or not, and we don't know because we don't have good data. Regardless, it's any death due to medical error is too much death due to medical error. And so we're going to end with that, with the HSSIP case for why we focus so much on quality improvement and patient safety. So hopefully this is just going to be an example, and this is again, one day in the life of, and it happens to be today's session. This is an example of how we're trying to help them become critical thinkers by looking at how good are the data that informs studies. How good are these data? What's actually causing us? What's causing us to die? So we talk about the difference between leading causes of death and actual causes of death. That brings in the whole discussion of social determinants of health, structural determinants of health, and we address medical errors in the context of health system science, setting us up for the importance of QI and patient safety. So hopefully, again, today's just a snapshot of what we're doing, and hopefully that helps you be informed of when they come to you in third year, what they're coming to you with. So block 3 is really where we have the heart of population health. And then in blocks 5 through 8, they're going to talk about change agency. There, for boots on the ground specifically, they're going to look back at the community health assessment that Molly and Aaron showed with you. So they're going to see that next week, and then they're going to see it again in block 5. And then hopefully by the time they get to you, they will have identified an actionable item. But this is an exact example, if we look at what we learned today, of where they're going to hopefully become critical consumers of the data, know where to find community level data. Every hospital that's a non-for-profit hospital has to do one of these. And then they can be informed what health systems can do about it. So boots on the ground, and I'm going to, again, get into a little bit more detail about that in the middle of this presentation, is where they take the information that Molly and Aaron shared with us today and try to actualize it or act on it. And then throughout blocks 4, starting in block 4, there we'll talk about population health concepts with respect to law and ethics. And then, I must not have updated this slide from last night. It must not have refreshed. And then in blocks 6, 7, and 8, they're going to see, again, how policy impacts population health. So to make sure that we're all on the same page, if you were me in first or second year, what definition would you use for health for first or second year students? How do you define health? Because I think it's important that we all have the same definition of health. Anyone feel like they want to speak up what health means, what the definition is?
Spiritual, emotional, physical well-being, and without illness.
Yeah, not merely the absence of disease or infirmity. Exactly. So they're going to get this in block 1, right? And then it's going to get reiterated in block 3 and in block 4 and throughout. And so just so that you know, this is the definition that the first and second year students will be coming to you as third year students. This is what they will know consistently, at least from an HSSIP perspective, as the definition of health. And we really want to focus on not merely the absence of disease or infirmity and not just physical health. Justin, I'm sure you would absolutely agree that our mental health is just as important as our physical health. And then today's discussion from all 4 of our speakers really talks about social well-being as well. Healthcare delivery system, I'm not going to belabor this too much, but healthcare delivery system, we want to make sure that the students are coming to you with an understanding that the healthcare delivery system is about the providers and the payers and the insurers and the government policy, the educational institutions, the research institutions. So the healthcare delivery system is not just the hospitals or the clinics. It's a much broader definition of who contributes to the health. And that gets back into that transdisciplinary or interdisciplinary approach that we're all in this, and what a payer decides to do or what the government decides to do absolutely impacts the way we practice medicine. So this is, again, what they'll be coming to you with. And then public health, what does public health mean to you? These are the slides. These particular slides are what we do in block 1. Does anyone want to take a stab at public health? Quiet crew today. All right. So public health is how we look at the organized efforts to improve health or prolong life and promote health. National Academies of Medicine, and this is what we focus on, is what we do collectively to assure the conditions in which people can be healthy. And that came up today. I think Aaron brought that up today. So our job in public health is to assure the conditions in which people can be healthy. And so if we take COVID as an example, really trying to ensure that people are adhering to the mitigation strategies that we know work. This is where it gets a little bit nuanced, and I would not worry about this at all. This becomes sort of an academic difference, but just so that you know, what we talk about in year 1 and 2 is population health is when you look at a group of individuals at either, so an insurer might look at a much larger group because there could be many different public health care delivery systems within that group, or a health system itself, Carillion itself, may look at what they're doing to improve the health of the population that they serve versus the public health, which is public health's responsibility. So it's beyond just the it's population health tends to be about confined populations, geographic or by insurance or by health, by catchment area, versus public health, which is usually a broader governmental associated intervention. Some people will take that latter definition. Again, this is academic, I wouldn't worry about it, but just so that you know the vocabulary that the students theoretically are coming in. I don't have any delusions that they're remembering any of this, but just in case one of them does. A lot of people use the latter term for what a health system does or what an insurance company does as population health management. Just again, FYI. What we then focus on is why the shift to population health, and we talk about this in the beginning, and then we really emphasize it in policy and comparative health systems, where we look at, we're just not getting our bang for our buck is the bottom line. So we look at healthcare spending, and we again address this there are multiple points. What we know about health system science is it's really hard to compete with clinical science and basic science. So we built in a lot of intentional redundancy. So they're going to see this in different contexts. In block 1, in block 3 to a lesser extent, in block 6 next year, and in block 7. So Dr. Stewart's going to be talking about this. I talked about it in November. He's going to be talking about it on Wednesday. We spend way too much. We also talk about the quality of our care is not comparable to other OECD countries. So we share these statistics and we update them. We have a whole session on comparative health systems where they get to go into a little bit more detail about the differences in quality of care in the United States compared to other relatively comparable countries. And then we talk about access and unequal access, and that gets, again, a lot of what was implied in the discussions that we had earlier this morning. So this sends the message, hopefully loudly and clearly, that the reason that we've moved to population health as a country and the concepts of population health are because we have historically not gotten the gains that we should have through isolated healthcare delivery systems and isolated public health systems. So together we need to focus on how do we achieve quadruple aim. Hopefully everybody, all of the clinical champions are well versed in quadruple aim. If you're not, I certainly would encourage you to do so. We talk about quadruple aim in block 1. So all of the clinical champions who taught in block 1 hopefully are very familiar with it. We'll be talking about it again. So small group, for Wednesday small group, for those of you who are talking about it, or those of you who are facilitating on Wednesday, it should be implicit in what we do in block this coming week. I think it'll be a little bit more explicit. In block 3, we talk about it as well. So quadruple aim, improve the patient experience, improve health indicators, measurable health indicators, reduce cost, and take care of the team that is caring for the patients. I'm sure you're all familiar with this. The students see this. They see different iterations of this. Some of this is equity, equality, and justice, sometimes it's inclusion, sometimes there are different third terms here, but they will see this coming into you, and so as they enter third year, and they will have seen it multiple times, both through health system science and through student affairs DEI. And here's just an example that we use. And this is where we try to transition very intentionally to the idea that you can't improve the population's health if you're not looking at social determinants of health. And I'm not going to spend a ton of time on this because this is really about making sure that we're all on the same page as we're teaching, as we're collectively teaching our students. So for those of you who are not yet familiar with the county health rankings, Erin talked about the county health rankings earlier today. The reason that we like to use the county health rankings in our teaching is that the health rankings are available in any state, anywhere in the country. And so we want to give them tools that they can use regardless of where they practice, where they ultimately end up in residency, or where they ultimately end up in practice. So this is the RWJ framework that Erin took that one slide. They re-envisioned it, but this is the framework. And as he mentioned, what is missing from this model is genetics. And the way that we explain why genetics, we collectively explain why genetics are not included in here, is at this point, the focus is on that which is modifiable. Well, genetics may be modifiable in the future at the population level. They're really not modifiable yet. So it may be that this will change as genomics changes, but in the meantime, we use this model. The other model that you see, and I realize I'm using my pointer on this on this screen, not this screen. So I'll move over here. Can you see my pointer now? Sorry, I was using it earlier. The other model that we use to try to ensure that students are looking at that big picture, are looking at the systems thinking, is sort of a version of the psychosocial model, but it's a socio-ecological model. So what we talk about, and if anyone needs more resources on any of this to feel comfortable teaching, just let me know. But the idea here is that as individuals, there are some factors that influence our health outcomes. So what's an example of an individual determinant of health? I'd love to get some chats going on. Thinking through this morning's discussions, what's an example of an individual determinant of health? And this is different from there's a hint here. It's different from the county health rankings.
New behaviors.
So that's really interesting, is whether individual behaviors belong here or here or here or here. And those of us who are, I would say that behaviors cross all of these spheres. That we historically have put behaviors here, and we've really started to move the behaviors out. And again, thinking about some of the discussions from this morning, if you have easy access to tobacco and there's tobacco advertising right across from your school, and the corner stores right near your school have cigarettes posted on top of candy, which is, we have a lot of beautiful images of that. How much of that is the way the community has shaped your behaviors? Or if everybody in your family is smoking, that dramatically impacts your ability. So you're absolutely right that I think most people think about behaviors at the individual level. We strongly encourage people to think about how all of these other spheres impact behavior.
So would it be something like gender?
Sorry, what was that?
Would it be something like gender at an individual level?
Yeah, so maybe genetics or gender or sex, depending so how an individual identifies their gender is likely to be at that individual level. Less less so than anything else. It's likely to be the way they are, right, from what we understand. And certainly sex, genetics, that's where individual factors would come in. First is relationship, and relationship, I like to use the example when I'm teaching. There was this great study by the New England Journal of Medicine years and years ago about the infectiousness of obesity, right? And I just give the students a really fast, easy example. The first person who starts ordering, do they order an appetizer? Do they order an alcoholic beverage? We tend to follow the first person. If the first person says, no, I'm gonna skip an appetizer and I'll stick with water, tends to set the stage for how. Now, are there going to be exceptions to that? Absolutely. But we are so influenced by the people around us. We're social beings. So we talk a lot about that. And then of course, community factors like what is the access and the quality of the schools? What is the access and the quality of the needle exchange programs? What is the access and the quality of the healthcare delivery system? Do we have, is it a health professional service shortage area? Are we in a rural community where we just can't access psychiatric services and we really have to focus on telemedicine, right? Those are community level, and then societal level is going to be our policy, which we get into great depth about in second year. But how do our policies influence our behaviors, our outcomes? So a classic example might be the federal policy, and they learn all about the different levels of policy, but a federal policy might be that Department of Transportation will only provide highway funding to those states that have passed blood alcohol levels for drunk driving. Right. So they see how that societal policy norm has influenced drunk driving behaviors. So is this information helpful? I'm just going to do a quick check-in. Okay. For those of you who I can see, I'm trying to toggle back and forth with my screen I'm going to see if I can see all of you. Hold on for a second. Doesn't want me to see all of you. I can see more of you now. So that's, again, hopefully this is not only giving you the concrete, these are the objectives that we're trying to cover, but also how we're trying to teach it. And hopefully it will give you more insight into the world that I live in. So social determinants of health, these, again, ways for you to see what we're doing. They do learn about Healthy People 2030. So if you don't know about Healthy People 2030, Healthy People 2030 is our national roadmap to population health improvement. And the cool thing about Healthy People 2030 is that it lays out what our goals are moving forward as a country, but it also gives specific indicators that should be identifiable, that we should be able to find at the community level. So it tells you exactly where the benchmarks come from, where we're trying to go, and where you can find that information. WHO definition of social determinants of health, and this is something that we really want to emphasize. And this is really consistent with what Emily and Rebecca were talking about in terms of structural competency. We really want the students to come to you understanding that social determinants of health are shaped by the distribution of money and probably most importantly, power and resources at all levels. And by definition, those are modifiable, right? So we're trying to make sure that, that slide didn't look too good, but we're trying to make sure that they understand that these are all modifiable, that these are all choices that we as society have made, social determinants of health are changeable. And then after we go through it all, we end up with this famous saying, your zip code is a better predictor of your long-term health and well-being than your genetic code. Have you all heard that saying before? Yeah. So they'll. It looks like everybody's heard that. So you'll have the students coming to you with a clear understanding that zip code is the better predictor than genetic code. They will see it at the local level. So those data that Erin and Molly presented, they will have seen that difference in life expectancy within the Roanoke Valley, and they will have seen it Hong Kong compared to Lesotho. I think, I can't remember what the lowest life expectancy is. They'll also understand that where you live within the United States, even if you're living in poverty, dramatically impacts your health. And they will have seen, again, this a couple of different iterations. So they should come to you fluent in this language because they will have heard it multiple times. Now, to transition to public health more specifically, we try to make sure that they understand that public health, oh, good, I'm glad. We try to make sure that that they understand that public health is the responsibility of everybody. There is this complex public health system out there, but the healthcare delivery system is part of the public health system, and vice versa. Just to make sure that everybody's on the same page, I make sure that the students understand the different levels of government, because I would say that one of the most common questions that I get about public health is why states are so different. So with respect to reproductive justice, why is it that Texas can pass a law about abortions at 6 weeks versus, New York? And I think it's critically important that they understand where policy comes from, because where they practice medicine is going to affect the way where they practice medicine is going to be profoundly impacted by where they practice. And so to make sure that they understand that really the states are where overwhelmingly laws and regulations with respect to health are passed, that the federal government has there is very little constitutional power for the federal government, except for interstate commerce and a couple of other things, so taxation, obviously, for the Affordable Care Act. So they get this with the idea that when they come to you, they're going to hopefully remember that some of the way we practice in Virginia is because we live in Virginia. And that's that larger health system overview. I just got asked the other day, apparently one of our school board members who doesn't think that children need to wear masks in school anymore, said something about CDC being the executive, or CDC being the fourth branch of government. And I mentioned that CDC is under Health and Human Services. What I should have mentioned is that Health and Human Services is part of the executive branch. So in fact, the CDC is the executive branch. It is not the fourth branch. It is the executive branch. Like, that's pretty basic. But I think that a lot of people don't understand that. So I try to make sure that the students come to you with an understanding of the basic structure of policy in the United States and where public health lives, which is right here, and where healthcare delivery lives. They will come to you with, hopefully, if they remember all of this, with a very clear understanding that within HHS, CMS takes about 95% of the budget of HHS, and that's where healthcare delivery is profoundly influenced, right? That CMS drives so much policy, and they'll learn that. It's not implicit in those slides, but they learn that when they learn those slides. So where this then leads, and I feel like I'm just yammering, so you tell me to stop or slow down. Where this leads, that's kind of the background, is to what is the role of the public health system and population health in the healthcare delivery system. And so if we think about all of the things that Rebecca and Emily and Erin and Molly talked about, this to me is the most comprehensive public health framework that looks at social determinants of health and policy, and where ultimately we end up seeing it in the healthcare delivery system. So the healthcare delivery system is here, right? We try to change risk behaviors through our counseling and education. We try to make sure that we're identifying people who have colorectal cancer screening. We saw some of those numbers from Molly and Erin today. We try to make sure that we're catching them with our clinical interventions, and we try to minimize mortality with everything that we do. But what we as a healthcare delivery, as healthcare providers, may not be as comfortable addressing are how do we look at the things that have the largest population health impact, and that's looking at livable wage, socioeconomic factors, looking at how do we implement tobacco policies so that it's easier for the default to be that I'm not going to be exposed to tobacco. That's my default, is I won't be exposed to tobacco because there are all of these policies in place. So this is where they're going to spend some time next week. Well, not next week because we're off next week, but the following 2 weeks, they're going to spend time with these two models. So they should come to you with a pretty good understanding that clinical medicine lives on this side of the whatever this is, the model, and lives in this part of the model. And what, from a health systems perspective, we're trying to do is make sure that we're empowering healthcare providers and health systems to influence these lower, more impactful population interventions. Does that make sense? Okay, I'm going to pause for a second. Any questions so far?
Will we also have this slide then?
Oh, absolutely. Absolutely. And one of the things I think we talked about is all of the slides that we have, we should dump into the Clinical Champions website, so that you can see, even if you're not teaching a session, if you want, if you have the time and energy, if you want to see the resources, all of those resources are available. I think we talked about that, right, Sarah? I see you nodding. I saw on the website that there's a place for it.
Yeah, we can. I'll reach out to Joellen if that works for that.
Yeah, I think we talked about that in December, Cynthia, but I don't know that we came to a consensus of the best way for them to access it. But I think, yeah, if there is a way that all of the PowerPoints could be uploaded maybe by domain, then they could see, because we have all of the objectives, but sometimes like the content, sometimes you can't necessarily tell from the objectives and the title of the session what the content.
Yeah, I don't think that we can do it by domain because it's just so, there's so much crossover.
Yeah, or by block.
Yeah,
and
we
then
can do
the
it by
title, the titles of will be in there.
Absolutely.
We can figure it out.
We can definitely do that.
Yeah.
And I don't want to overwhelm you. So if this is information that isn't, I think the best thing is for us to just kind of vomit it out there. But anyone who wants one-on-one, where can I find the stuff that you're doing about this because I'm teaching this, then we can do that one-on-one sort of equivalent of precision medicine, right? Where I'm working directly with you to make sure that you have the resources that you need. Just like exactly like Kelly and I did. Okay. And I don't have a ton of slides. I just wanted to show you where we are. So the other thing that we talk about, and this is in block 3. So what we just, that model they see in block 1, and then we do the deep dive into block 3. And we also in block 3, just again, so that you know, talk about the difference between health promotion and health and disease prevention, which really is gray. There's a very significant overlap. When we do counseling about nutrition, is that promotion or is it prevention? Well, it's really both, right? But they will learn about health promotion, disease prevention, primary, secondary, and tertiary prevention. I don't expect that they're going to remember all the details, but they will have been exposed to it. And then I mentioned this last time, and I think that from a health systems perspective, this is where I wanted to spend a little bit of time. And we heard about this with going upstream with asthma. The 3 buckets of prevention, this is the language that we use in public health, and that's to look at traditional clinical prevention. That's going to be your mammograms, your colorectal cancer screening, your osteoporosis screening guidelines, right? That's the traditional clinical prevention. Then there's the community-wide prevention. And the community-wide prevention would be the things that I just talked about: tobacco policies, COVID policies, diesel policies, removing lead from paint and gasoline policies. Those are all the traditional community-wide prevention strategies. And where there's tremendous growth in our health systems is in this innovative clinical prevention. And pretty much you can take what Molly and Erin were talking about today, and everything that they're talking about today is really this innovative clinical prevention, where we're taking the healthcare delivery system, we're taking the public health system, where we're saying, how can we work together? Whether it's increasing access to healthful foods through Morningside urban farms, or whether it's putting clinics in our most underserved communities like Fallon Park, because the children aren't necessarily going to go to Tanglewood, right? So maybe we need to go to them. Because there's so many social determinants of health that are acting as barriers. And Jackie, your comment about the non-compliant patient, the students will have heard me screech about, we don't use compliance, we use adherence, right? Because it's such a loaded term. So they should be pretty well versed, pretty fluent in that by the time they get there. But hopefully this now helps you take that context of what you heard today from Erin and Molly and put it in this not even a theoretical framework, this actual framework that's happening in health systems across the country today. This gets a little bit more wonky, and I'm questioning whether or not we should include this. When we think about these buckets, there are 2 websites, and I like to give the students tools that they can use no matter where they go. So I like to use the federal places like CDC, or the national programs like RWJ. And in this case, the CDC 618 initiative there's 6 priority areas, and under these 6 priority areas, let's see if this works. You can actually go and see evidence-based strategies that healthcare delivery systems, so CDC 618 is specific to healthcare delivery systems. It's specific to what providers and insurers can do to increase health outcomes in these 6 areas. So we teach them that. Yeah. So nutrition is not on this. I think part of it is because you can see some of it maybe within the diabetes prevention, but I think it's because it's hard from a healthcare delivery perspective to effectively address weight control. I think that there's still a lot of evidence. These are all evidence-based, evidence-proven strategies here. But that's a good comment. And what I will tell you is that when the students, like this week in this week, they will learn that the leading actual cause of death is nutrition. They're going to see, leading actual cause of death is nutrition. I just mentioned that. So they're going to understand from a population-based perspective why it's critical. But they're also going to see that there's some challenges with getting those data. So they're going to be exposed to CDC 618. I'm wondering whether this is something that I should keep, and I'm happy to hear from you. If it's not, I'm just trying to give them benchmarks that they can see that are going to be available no matter where they practice. And then this is a specific example. I just showed you one, but it's to dive into the details. They get a chance to dive into the details. And then the other one is High Five. So they're two separate CDC initiatives that are together. High Five is addressing the lower level of the health impact pyramid. And it's, again, evidence-based public health strategies. So in the public health part of Block 3, they're going to talk about this. In the healthcare delivery system part of Block 3, they're going to talk a little bit about this, just as examples. Now, I mentioned that pulling all of this together, the idea behind Boots on the Ground is that they pull all of this together. So they get to go out to the urban farms. They get to, hopefully this year they'll be able to go out to Fallon Park. And one of the things they do is they come and visit me at the health department. And this was my quick opportunity to share with you what they learn about public health. So we use a real hepatitis A outbreak. This was prior to Famous Anthony's. I will incorporate Famous Anthony's because teachable moment, right? But what they learned then is the importance with respect to infectious diseases, that as providers, they must report reportable diseases. That's a policy, it's a law. They'll hear that CDC has passed this guidance, that federal policy, the state passes the law, and the locals enforce the law. Like they'll see this in action. So they get to actually do an outbreak investigation. We give them information. They are the contact tracers, the case investigators, they're the environment, they take roles. They are the environmental health specialist who goes out to the restaurant. They then see what happens with that information. So they learn about the epidemiologist. They learn about the nurses that are going to go out and offer hepatitis A vaccine at the facility that has had the outbreak for all of the workers. They learn about the social determinants of health, that a lot of our food handlers are people who are living in poverty, who don't have sick leave policies, who are disproportionately likely to get Hep A because they're disproportionately people, and these are just, this is just the reality, they're disproportionately people who may have substance use disorder. Or who may be incarcerated. And so they learn all of this, and they learn it with the idea that public health is a team of interprofessionals who work together. And when we do an outbreak, we bring in, as I mentioned, our epidemiologists, our nurses, our health educators, and our environmental health team. So they see all aspects of what we do. What's not implicit in this, but what is explicit when they come here, is they learn that in public health, we run the WIC program. So they learn about nutrition, at least from a maternal and child health perspective, from visiting us at the health department. They learn that we have early intervention. So for our children who have developmental delays or who are suspected of having developmental delays, we provide those services for those families. They learn that we have STI clinics and TB clinics and vaccination clinics. So they learn that we have a clinical component as well as the stuff that we've now become known for, which are the COVID police. And so hopefully that also helps you understand what we do. What they do is they come here, they do a tour, they get to see, yes, we do restaurant inspections, and we also inspect every camp. We also inspect every mobile food market, we inspect GoFest. And they learn what we do in public health to improve the population's health. They learned that bucket that was up there. And that's really, I think that the goal of health system science with respect to population health and public health, so for us, we really are going to use those fairly interchangeably, is that together we can achieve that quadruple aim, really focusing on improving the health, getting back to the WHO definition of health, of the people that we collectively serve. So that is what we do in 2 years of health system science from a population health perspective. I didn't focus on the clinical informatics. I didn't focus on QI, patient safety, but hopefully you can see that with the way we present it, all of those other elements then feed into it. Does that make sense? And so with that, just, are there any open discussion, any questions that you may have? And I'm going to stop sharing.
It's not a question. I'm just saying it fits very nicely with what we learned this morning about,
That was
structure.
Sarah being smart and putting us together.
Yeah, really nicely flowed together. And I think that my takeaway from this, which there's a lot, is going to be that little individual bucket feeding into relationships and societal, and that there's very little choice at the individual level. A lot of it, what we think of as choice, is not actually choice. It's determined by so many other factors way bigger than ourselves, which is a good perspective, and I'm just gonna think about that.
Yeah, and we try to hit them pretty hard. And so I'd be interested in hearing from those of you who did first block one. Do you feel like we hit them pretty hard with that in block one? I feel like we do, but maybe that's just a misperception on my part. Sarah. I'm trying to remember who else. Lubna, Andrew.
Yeah, some of this stuff is repeated, but a lot of it bears repeating and reinforcement.
I think also, it's just such a change, like the shift from what they'll get in the classroom in M1 and M2, which is like the ideal, and then getting plunged into the system, which is very not ideal. And so, having, not to be blunt or anything, and also being surrounded by a lot of providers who, maybe knew this once, but in the day-to-day, sort of forget, just like Vidya said, which, she said so beautifully, that when you're looking at the patient in front of you, and the students too, they're so focused on like what they can do, and it's hard to remember to think about the other factors. And so making that connection, sort of, intentionally bringing in like this awesome foundation, Cynthia, that you are setting up for them, and then pulling that in through clerkships where that thread is just not quite as strong when you're in the clinical setting, or it might, they'll see where it's breaking down basically. And so sort of re-threading that back through, I guess, is one way I think about it coming back up in the clerkships.
Yeah, and we do try to make sure. So one of the comments we got the first year that we did this was that it was depressing, and they felt like, what was the point? We thought that we were building in solutions in everything that we did, so that they did feel empowered, because, Natalie, you and I have talked a lot about the importance of helping them feel empowered as future change agents, not even future change agents. The point of boots on the ground is that they're going to present to Erin and to Shirley next in a week. They're going to present their ideas of what we can do differently within our communities. And so we really are trying to help them see that they can make changes even starting in medical school, bringing in those solutions, but building on those solutions in the clerkships, I think, is critically important. I see Jackie had a question about, oh, no, that wasn't negative. Jackie had a question about trauma-informed care, ACEs. I mentioned ACEs a couple of times, probably not formally, it happens organically, because I don't know how it wouldn't happen organically. We don't specifically talk about trauma-informed care. I think one of the challenges with this, and I am so open to any solutions, is trying to balance how much detail we get into in any given topic. And I think that's what I would love. I don't know if all of what you guys are doing is solidified yet, but I think it'd be amazing to have something on trauma-informed care. I'm trying to figure out where the biggest bang for the buck is. And Natalie, I'm going to pull you in on this one too, that I think we're constantly struggling about where is it most impactful to talk to students about RVUs? Where is it most important? Where is it most impactful to talk to students about structural and social determinants of health? Where is it most impactful to talk about trauma-informed care? And I think that we still haven't gotten that answer. So I would love your feedback as folks in the clinical clerkships. If you think that putting trauma-informed care, Sarah, I'm thinking we might even be able to pull that into one of the ethics cases. If you think that would be helpful for us to introduce earlier on so that you can build on it, I think that's a great idea.
I can also talk to Jacqueline. I don't know, one other person to think about talking to would be Taryn Schmidt-Dalton, because I think there may be in some of the sexuality anyway, I'll pull what I have for you, but that's another person to connect you to see what they do for M1, M2. Sorry to interrupt.
No, that's great.
I give I give a webinar as trauma and like changes you can make for your daily practice as gynecology to incorporate trauma-informed care into your everyday life. And I kind of added it in one of the case scenarios for our clerkship conversation lecture. But I think there's a couple of places I think it could be incorporated. I think in having those difficult conversations in discussing sexuality, I think it would be easy to incorporate, because those are, when you look at disclosures and really talking about what patients come in with when they come into the visit, and some of their distrust and pain and suffering that they bring with them. A lot of that has to do with ACEs and some of their experiences, and some of it as it relates to negative experiences that they've had that are quite traumatic in the hospital system.
Yeah, I think that as Natalie just pointed out, the other thing to keep in mind is that clinical science is going to have opportunities to address some of this. PBL, so how to have difficult conversations with patients, is pretty well covered in PBL. So we could potentially connect with, and I'm not taking notes here, so I'm going to pause for a second and do that, is whether there's trauma-informed care in any of the PBL objectives, where the students then present the information themselves. I think that would be a great place to have cross-pollination of some of these key topics. And I do think that that's one of the things, is that we have this dedicated course in health system science, but health system science impacts everything. So there are a lot of health system science comes up in PBL, and again in clinical science, but also like some of the concepts of equity come up in research as well. So one of the things that we can do is try to, Natalie, in our crosswalk, try to figure out long-term how we map it, not only our internal mapping, but map it to the other three domains.
Yeah, definitely. I think it's one of the great things and tricky things about HSS is it truly does sort of touch everything. And so much of it, weaves together, just like all of our speakers have mentioned, everyone sort of opened their talk today where it doesn't fit perfectly in this little wedge. And, the AMA, it's a beautiful picture for them, but in reality, of course, it's, they're all going to sort of overlap. So.
Oh, and that just reminds me, so like a lot of the discussion about cultural humility actually happens with student affairs DEI. So we also have to think about that.
I did have, if any of you all are want to touch base with the folks who are running the DEI thread, it's Drs. Witcher, Jelly Witcher, and Dr. Kemi Bankole. I have been talking to them about a couple of sessions. So like, for example, Justin, for like the spirituality session for the M3s, Dr. Milam also did a session for the M2s this year, but a lot shorter. Their sessions in general are pretty short, I think like 50 minutes. But if anyone wants to, connect with them, I'm happy to connect you, just reach out if you think, and they're really excited and happy to sort of work with us and talk to us about everything we're doing and how we can, work together better.
I pulled up the DEI portion of the medical school website while Dr. Hester was talking, and it says culture is just over and over again. Culture, 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 culture. I was like, I bet Dr. Hester probably wouldn't like the way that we've worded this website very much.
Yeah, I will say, so Jelly, Dr. Witcher is co-teaching with us in block 3. And we've been using the term cultural humility, trying to get the concept of humility just goes a really, really long way in any of these models. But our talk is social and structural determinants of health. So we're trying to make sure that we address the structural components. But the language is tough. The language is really tough. And I know you guys have to, is there anything else before you move on to your next thing?